move to our next speaker. So Professor Miguel Arraez undertook his neurosurgery residency at the Department of Neurosurgery at the University of Granada prior to fellowships in UK, US, and France. Main clinical interests are in skull-base surgery, and he's the chairman of the Department of Neurosurgery in Malaga and professor at the University of Malaga. He's also founder of the Arraez Institute for Advanced Neurosurgery, and has held a number of positions, including past president of the Spanish Society of Neurosurgery, chair of the committees of the WFNS, and is currently president of the World Academy of Neurosurgery and vice president of the WFNS. So welcome, Professor Arraez, who is going to give us a talk on vascular complications in skull-base surgery.
Thank you very much, Dr. Holsgrove. I hope everyone can hear me. Can you? Okay, thank you.
Yes, we can, thanks.
Okay, so, well, my topic is about vascular complications in skull-base surgery. But before starting the presentation, I'd like to thank Professor Naren for his kind invitation to participate in this memorial and being among all these prominent leaders. Congratulations on this initiative regarding our very good friend, Fred. I like also salute and send the warmest hug to Gina and say hi. Okay, hi Gina. Well, this is Professor Gentili. I think it was 2019 in the International Conference on Complication in Neurosurgery. In this talk, he was talking about the mainstay of his practice: dignity in the case of adversity, empathy, compassion, gratitude, honesty, and of course, all these issues are very much linked to one of his worries along his career, that is the avoidance of complication in neurosurgery, and particularly in his prominent field, skull-base surgery. So my presentation, my humble contribution to this memorial will be regarding complication, particularly vascular complication in skull-base surgery. And well, all the cases we are going to see are personal cases. And let me share with you my mistake trying to improve our neurosurgical practice. If we click, if we click skull-base surgery in PubMed, we will see more than 15,000 results. If we click skull-base surgery complication, we will see that almost 1 out of every 3 publication is related to a skull-base complication. And if we just click regarding, 1 second. Okay, if we click skull-base surgery vascular complication, we will see more than 1,000 medical references. That is roughly 7%. And I think these complications are important because in our practice, unlike this very well-known slide representing the way planes are crashing, you have to see a compilation, an accumulation of, let's say, a terrible situation, just leading to the crash of the plane. In skull-base surgery, and particularly in vascular complication, you only have one chance. And this is one beautiful picture of the SS North in 1909. And this this boat was just usually going from Ireland to the east coast of North America. But you can see on the right side, Rockall. This is a very small island, very small rock that, according to the tide, can be high, as low as 12 meters, or, as you can see here, just in the middle of the ocean. And unfortunately, the SS North, you can imagine how huge the ocean is unfortunately crashed, and just almost half of the people inside just was dead. So this is how vascular complications are coming. And let me share with you some cases. This is case number 1. This is a 57 years old patient with a left cavernous sinus, atypical meningioma, operated on after that radiosurgery. Just 1 year later, right optic contralateral optic nerve invasion, as you can see here. And this is the way we try to make optic nerve decompression and removal of the tumor. We are going to do clinoidectomy with the ultrasonic drill, and then cutting dura that you can see here infiltrated by the tumor, bring the optic nerve. And then in one of the steps, we have this bricks bleeding that later on, fortunately, we managed to control that easily. And we realized that optic artery had come in from the dura. So this complication was related to anatomical variation at the ophthalmic artery. And then after this complication, we went to see the literature. And you can see one publication in 2020. I mean, this is not, this variation are not variation that you could see published decades ago. This is something that is still on the interest of neuroanatomists, and you can see in this article several variations. Sometimes ophthalmic artery is coming intradurally, sometimes not, sometimes even coming from cavernous sinus. This is another publication, 2020, double ophthalmic artery arising from the internal carotid and accessory meningeal artery. This is 2020, another publication, 2020. I think this is a topic still alive and just causing a lot of interest. And well, summarizing, this first complication is coming from this first category, anatomy-related complication. That could be descent ICA canal, variation of the sphenoidal septa, short distances between ICA, and this complication fell into this category of anatomical variation of the vessel. This is case number 2. This is a young patient, 14 years old, with this chordoma, operated on in 2000. At that time, we used to manage clivus chordoma by means of transmaxillary approach, the very well-known open-door maxillotomy of Professor Crocker. A nice result at the sagittal view. You also have, of course, to see the axial view. We had some remaining tumor, not infrequent, when doing transmaxillary approach. And we just try to remove that part with far lateral approach and then combining with radiotherapy. But the patient in 2014 came back to our clinic with this recurrency at the petrous apex and parapharyngeal space. By that time, following, I have to mention the same as Professor Gentili did. We moved for certain cases from open skull base to endoscopic skull base for certain cases, not all the cases. But during this operation, you can see ICA, you can see the extension of the petrous apex. There was a bleeding of the carotid artery. We just put a Foley balloon. We took the patient to the angiography ward. We realized some collateral flow, and we just decide a carotid sacrifice. This is during the initial step at the angiography. You can see the impingement of the Foley balloon, but in spite of this, some leak of blood. And then after realizing very good collateral flow through PCAM, we just, the vascular colleagues just sacrifice carotid artery. This is another complication, in that case, related to pathology. There are several aspects of the lesion that may provoke some increase in the risk of bleeding: ICA displacement by the lesion, distortion by the lesion, adherence to ICA, previous extended surgery, previous radiotherapy, and in some cases of pituitary adenoma, previous bromocriptine therapy. This is case number 3. This is a patient with acromegaly recurrency, sorry, reoperation. You can see one of the picture. You can imagine the complexity of this lesion. For de novo cases, we very seldom use neuronavigation in pituitary surgery because anatomy is guiding you very well. But for recurrency, we always use neuronavigation. But in the middle of the procedure, the neuronavigation failed, and you can hear how, unfortunately, we just provoke some bleeding at the right carotid artery inside cavernous sinus. We managed to control, let's say, easily with some Foley balloon, Flosil, and just we realized that everything was fine. We finished the operation, but the day after we did the CT scan, and we just had this surprise of this pseudo aneurysm that was coiled later on. I think this complication is coming. There are several issues related to skill and resources, inexperience in skull-base surgery, lack of adequate instrument and equipment. That was unfortunately the problem, and of course trying to do radical resection if the tumor is very adherent to the carotid artery. Case number 4 is also related to pituitary surgery. This is a flat cella. This is a 20-year-old patient with a pituitary adenoma. You can see this is a flat cella in the coronal view and also in the sagittal view. This is another indication in our mind for neuronavigation, but we were confident, and unfortunately during the procedure we provoked some laceration of the left ICA. We just controlled that, but in any way we took the patient to the angiography ward, and we could see some narrowing of the carotid due to intraluminal hematoma, no pseudoaneurysm, some small images of ischemia, although the patient was neurologically intact, and this is angio-MRI 1 year after, 1 month after, and 1 year after the operation with the same image and considering normal. This is, of course, again, a complication related to the cellular, in that case, to the cellular anatomy. We mentioned before some other anatomical consideration that may lead to a carotid injury during endoscopic skull-base surgery. I think that going to the medical literature, there is a very good paper from the group of Pittsburgh, Paul Gardner, and there are several very good considerations. First of all, well, of course, regarding the management strategies for controlling arterial injury during endoscopic skull-base surgery, we have to take into account that fortunately around 80% of the patient will tolerate ICA sacrifice, but of course the rule of the BTO and physiological monitoring is very important. There are also considerations regarding bypass, prophylactic bypass of emergent bypass. I had to realize that we went to this consideration basically about the prophylactic measure and let's say trying to be in advance of potential complication after reviewing our cases, and also important the way of trying to control the hemorrhage, bipolar electrocautery, only in cases of avulsion of perforator or a small opening, the possibility of aneurysm clip. That is not easy in endoscopic skull-base surgery. We have to mention that muscle seems to be the best packing agent, trying to control the bleeding, and the possibility of suture is also, let's say, more theoretical than a real possibility. Important to mention that the management depends on the kind of lesion. We can have perforator avulsion, so bipolar could easily solve the problem. In case of laceration, direct injury, if a small, bipolar could be solving the situation. If the lesion is large, bipolar may impair the situation. An angiogram may give the clue and the possibility to endovascular treat the lesion. If the vessel is intact, you can repeat the angiogram and you do some sort of follow-up. If we see some pseudoaneurysm, of course, you can, in this location, usually the cavernous portion of the ICA, you can take advantage of endovascular techniques. That could be occlusion of the AC, or it can be coiling, and so. And according to the outcome of the patient later on, if the perfusion is compromised, bypass can be considered. Important to mention that sometimes the indication of the operation is related to a tumor and to a tumor involving ICA. In cases of benign tumor that are recurring and underwent radiotherapy and or malignancy with the aim of radical resection, it's important to consider the possibility of the BTO before the operation. Because if BTO is negative, you have to consider the possibility of preventing bypass. And I think that regarding endovascular management for that cases, it's important to mention that may give a very important solution in case of active extravasation, pseudoaneurysm, or ICA stenosis from overpacking of the bleeding. I have a couple of cases more that are not endonasal cases. This is a young patient with craniopharyngioma. We can see here a recurrency after transsphenoidal surgery and radiotherapy. You can, maybe many colleagues could be in favor of endoscopic approach, but we just pay attention to that view, and you can see how the anterior communicating artery complex is surrounded and probably, let's say, very stick and very adherent to the tumor. So for cases like that, if you have to control in the best possible manner the neurovascular structure, we are in favor of intracranial, transcranial approach. And for those, let's say, cases that may be complex, already irradiated, previous operation, we like the interhemispheric, anterior interhemispheric approach and see what happened. This indolent maneuver, some bleeding of the ICA that was controlled, but unfortunately followed in the few hours later with infarction. So as a summary of this case, just taking into account the possibility of very easy damage of the internal carotid artery and some other vessel if the patient underwent previous operation plus radiotherapy. Of course, I mentioned that to our mind and in practice, if you want to control any potential bleeding, transcranial approach is much better. And this concept are coming from our philosophy regarding craniopharyngioma. This is the way we try to manage craniopharyngioma: transsphenoidal, nowadays endoscopic, craniotomy, partial removal, intracystic therapy, the different situation, young or patient, hypothalamic involvement, intracellular, intracranial, infra, suprachiasmatic. But we go to the last three, let's say, lines: previous radiotherapy, previous craniotomy, and the terrible combination of previous radiotherapy and previous craniotomy usually in our practice led us to do craniotomy instead of transsphenoidal approach. This case fell into this category, pathology related, in that case due to previous surgery and previous radiotherapy. This is our last case. We have two more cases. This is one young patient operated on many years ago And probably today we would have done some transsphenoidal endoscopic approach, even knowing that resection is going to be subtotal, but it was operated on maybe 18 years ago or something like that, a 12-year-old patient with a osteosarcoma of the skull base, and see the combination of factors. You can see the subfrontal extender approach that we use. In that case, optic nerve compression, exposure of orbits, but we also pay very much attention to this combination. In encasement of carotid artery, you can see how narrow the lumen is. At the same time, this lesion, high vascular lesion, not amenable for endovascular treatment, and the possibility of hypotension during the operation due to this high degree of vascularization and the, let's say, the compromised flow in both carotid arteries. So a stroke is one of the potential problems. And talking about the stroke, vascular complication is not only related, of course, as I mentioned before, to bleeding, but also to ischemic events. This is a 70-year-old patient with recurrent chordoma at the petrous apex. The patient was operated on 15 years ago with satisfactory result, then proton beam therapy, and this recurrence due to the age and relationship with carotid artery, we try not to be too much aggressive. We did let's say, satisfactory removal, but in the postoperative period, this is the CT scan with showing fat and the extension of the resection, but unfortunately, the patient suffered an MCA infarction, and in spite of thrombolysis, the patient died. And it was probably related to the manipulation of a carotid artery in a patient with probably some arteriosclerotic component. So vascular complication in skull-based surgery, avoidance and management, we have to take into account variation in anatomy, tumor characteristics, and important whether or not the patient underwent previous surgeries or previous radiotherapy. We also have seen some, outline about the strategy in case of rupture. I like to insist in the issue of the muscle as the best potential hemostatic agent, and needless to say that in cases of hemorrhage in a carotid artery, the role of endovascular management is of paramount importance. So I think that linked to that, the need, if you are dealing with a carotid artery lesion, to have available and nearby some endovascular facility. Success does not consist in never making mistakes, but in never making the same mistake a second time. So I think this is something important. I like to add something after the, let's say, review of the medical literature. We never use that, to be honest, but I think we have to take into account the possibility of the use of adenosine. That is something, let's say, familiar in vascular neurosurgery, but also in cases like this, we have shown internal carotid artery rupture, maybe adenosine may facilitate the control of the hemorrhage. And well, I think we have heard many things about Fred Gentili. Just to finish my presentation, as a human being, and of course, we have listening to several comments regarding Fred as accomplished neurosurgeon with a high sense of duty. He has trained hundreds of neurosurgeons, and just Dr. Gentili, my very good friend Mauricio, mentioned that he usually used to be the last one just quitting the auditorium, but also I have to mention that very frequently he was the first one coming to the auditorium just to give a talk. I like to, there are many virtues that we all have appreciated, many of them already described by the previous speaker, but I like to insist in one of the characteristics of Fred Gentili. Usually you see in conferences, meetings, skull-based surgeons that are endoscopic skull-based surgeons or classical open skull-based surgeons. And I think that the mind of Professor Gentili had the flexibility to adopt the latest endoscopic technique that came to stay, of course. I humbly did the same, and more or less at the same age, at the mid-50s, because we realized that the endoscopy has clear advantages and clear indications in certain cases. In our talk, the talk we saw from Fred Gentili some ago, he was talking about the hybrid model of a skull-based surgeon. He was a perfect example of the hybrid model. And I think that this is something important for the youngest colleagues in the audience. We have been witnessing endless fighting between the youngest colleagues and the senior colleagues, endoscopy versus open skull-based surgery. And it always brings to my mind some anecdote of the mid-50s when in a meeting of the, I think WNS, Dr. Clower trying to convince several old neurosurgeons that used to do the spinal cervical compression by herniated disc by means of posterior laminectomy. He was trying to convince they all, and there was a very bitter discussion because Dr. Clower was a very bad-tempered person in some cases. He was fighting with Dr. Raff, and finally Dr. Clower said to Dr. Raff, "It is clear that you cannot teach new tricks to old dogs." I think that our mind has to be flexible enough as Fred Gentili minds has been during all his career to adopt new techniques. But we have also to mention something about another facet of my dear Fred. Fred used to be a very funny person, and we spent many hours in the auditorium and many hours outside the auditorium talking, joking, and enjoying life and enjoying friendship. And this is something that he did in many continents, in Asia, in Middle East, Africa, Europe. We used to make jokes about this very funny slide and his membership to the Holy Pituitary Trinity that you can see here. And I like to especially thanks again the Toronto group and Fred Gentili for his kind invitation. In 2019, I was there as visiting professor. It was something absolutely unforgettable, but I like to mention a very important person that took a special, let's say, protagonist during my stay there, and I like to mention the wonderful friendship and hospitality. Thank you very much, Gina, for the time we spent together. You are a real giant as well. We are talking about giant of neurosurgery. We have heard Professor Spessler, one of the giants of neurosurgery. By the way, Professor Spessler, I hope you will be very well very soon. And Gina, you are also even more giant than the bear that is photographed with you. I had the pleasure to have Fred Gentili in Malaga. It was in 2019 during one of the WFNS courses. And this is one of our favorite slides in our family. My wife Cinta and me are smiling with our very close friends, Fred and Gina. I'm afraid that we all have lost a great friend, a great person, but also neurosurgery has lost a great and a giant neurosurgery. Thank you very much for your kind attention, and thank you for giving me the immense honor and pleasure to participate in this memorial.
Thank you very much for your talk, Professor Arraez. Does anyone have any questions? And if so, could you either raise your hand or post them in the chat? Whilst we're waiting, if I could ask you, myself as a non-skull base neurosurgeon, the thought of a vascular injury during endoscopic surgery fills me with dread. Could you just take me through the steps that you sort of take in that scenario if you lose your field of view through a vascular injury and you've effectively got read out of the screen?
Yeah, well, excuse me, I'm trying to just stop sharing my screen, but I don't know what happened. I don't know whether Naren, you can control that and stop sharing my screen. Naren? Well,
I'll try.
Thank you, because just I eliminate some controls from my Zoom screen. Okay, thank you very much. So, well, just going to the question of our moderator. Well, I think that I've been, and I am very much in favor of endoscopic skull-based surgery, but endoscopic skull-based surgery has several problems. One of the problems is the capability to maneuver and to make control in difficult situations or very fine, let's say, movement and so. So according to that, if you have, and unfortunately I have had, and I have shared with you, if you have such a terrible complication, the main problem is trying to stop the bleeding. And then after stopping the bleeding, you can think about and you can try to see whether you have exposed enough internal carotid artery, trying to apply a clip, or you have to try to just controlling the bleeding and being the bleeding stop, just increase your exposure of the ICA and things like that. So every case has been different for us, but what we have done in some cases I have shown is just inserting a Foley balloon. Foley balloon, and you can put in between muscle, you can, of course, Surgicel, you can try to use Flocil. What we try to do is just to inflate a Foley balloon. Usually, Foley balloon is very much adjust to the sinus, and then you can try to think. What we do is just, as I mentioned before, to interpose Surgicel, and what we try to do is just releasing the pressure of the balloon, and at the same time inserting Flocil in between the area of the bleeding and the Foley balloon. If the bleeding is, let's say, important, you have to take the patient immediately to the angiography ward, because nowadays, fortunately, there are several, as I mentioned before, several possibilities for some definite solution that sometimes is by means of the sacrifice of the vessel, but sometimes not.
Thank you. And sort of on that note, you showed some good examples of where you'd worked with your endovascular colleagues to intervene where necessary. In terms of the logistics of that, are you operating in a hybrid theatre, or would you temporize the situation and take the patient through to the angio room, or would they come through to you and sort of do their best with the C-arm? Well,
fortunately, our practice is based in a university hospital, and we have 24 hours on-call endovascular colleagues treatment. Usually, these are, let's say, a scheduled operation done, let's say, during the morning or at the beginning of the afternoon. So the colleagues are there, but if not, they are at the same time, they are not on call because of the possibility of neurosurgeons needing them, as you can imagine, but they are on call because of the stroke plan and treatment, thrombolysis and embolectomy and things like that. So fortunately, they are fully available. To be honest, we also do pituitary cases in private practice in some hospital that not necessarily has this 24-hour availability of endovascular surgeon. And from those cases and the review of what we have done and the problem I have very much, let's say, select the cases I'm going to operate if I don't have a full availability of endovascular colleagues.
Thank you.
This is one of my, let's say, honest conclusion, apart from trying to do a very, because, you know, we have to operate this case, carotid this way, that way, but now before any operation in which the tumor is very much compromising ICA, I very much plan what I can do and what the problem I can have.
Thank you. Any other questions for Professor Arraez? Yes, Andre.
Yeah, well, maybe a little remark on the flow seal. I mean, it's wonderful for hemostasis, but I would warn against spraying or putting the flow seal very close to where you have the bleeding site, because about a year ago I had to do as a legal witness a case where they could easily stop the bleeding, but they completely obliterated the carotid. Yeah. The patient died from a massive infarction. So that's a warning. But I think you said it. You should place something different, and you can tamponade that. We have seen patients coming from indeed private centers where they do regular pituitaries without any endovascular cases. When it happens, it's very rare. But then they tamponade, and with tamponade they send it even by ambulance, not even by helicopter, and then we can deal with it. It is a possibility. You have to do this. So I would not argue that for every pituitary case you need an endovascular colleague standby, for sure not. But for the difficult cases, the recurrent petroclivals, the recurrent chondrosarcomas, etc., and case carotid, yes, of course. That's part of the plan. Fully agree. It's a great talk, Miguel.
Thank you very much. Thank you, and thank you for your wise, appropriate comment, as always. And as a matter of fact, honestly, in the last case I showed, we had the doubt whether the infarction was provoked because there was some brisk bleeding. We couldn't see the origin. I mean, in the lady with the, not all, 73 is not all, but the lady with the recurrent chordoma, and we are not sure whether it was due to the manipulation of the artery or because of the flow seal getting inside the artery. Thank you very much. Yes. Thank you very much, Andre. Thank you.
Great. Well, thank you, Professor Arraez, and thank you, Dr. Spetzler. So that concludes this section. So I'll hand back to Naren for our next speakers. Thank you.
Thank you very much, Dan. That's a great session. We had fabulous lectures, talks, very insightful from Dr. Spetzler and Professor Arraez. And thank you very much for chairing this meeting session so great. Well, I really appreciate it. Professor Andre Grottenhuis sent me a message. I mentioned earlier that Jeffrey Jefferson had co-founded the SPNS and also was the leading light in founding the WFNS, but he also mentioned that he was the instigator for the European Association of Neurosurgery and was the first president. Obviously, Professor Grottenhuis was a president.
No, the first president was Dr. Johnson from Mr. Johnson from Manchester.
Okay.
But Geoffrey Jefferson was one of the initiators, one of the 5 who really started in 1957 already by drafting a possible European association.
Great.
Oh, thank you.
Manchester was important for us.
That's great, and it is still. And I'm sure Dan will be happy for any of you who want to visit Manchester. Is that Dan?
Yeah, of course, definitely.
Thanks. Thank you very much.